This is Committable. I'm Jesse Mangan, and for this episode, we're talking about Peer Respites. And I'm very lucky to have with me here Jason Robison. Jason, do you want to introduce yourself and say whatever you want about who you are and the type of work you do?
Pleasure to be here. Thank you for this work. My name's Jason Robison. I'm the Chief Program Officer for SHARE, the Self-Help and Recovery Exchange. We are a peer-run organization in Los Angeles, California, and we have about 80 staff. All of them have lived experience and are certified as peer support specialists in different capacities, right? So we've got frontline workers, supervisors, program managers, coordinators, directors. Everybody is a peer and is trained to understand how to use their lived experience of mental health, substance use, homelessness, incarceration, trauma to connect with others and form relationships that help others and support others on their pathway to recovery, however they define recovery. So we're a contractor with the state of California, with the county of Los Angeles, which is the biggest county in the nation. And we do peer-run housing that is a type of recovery housing that's not necessarily abstinence-based. So for people that want a drug-free environment, we've got that. For people that don't have an issue with drugs or alcohol, we've got housing for them as well. And people can change their minds, right? They can go back and forth and maintain their housing. And we literally move people from the sidewalk into housing within 40% move in within 48 hours of calling us and saying they want housing. And that's because we use the available housing stock in Los Angeles rather than developing new construction. So we use single family homes. LA County has approximately 10,000 single family homes on the rental market at any given time. And that's the housing stock we use to build this kind of housing stock. So we've got 45 houses throughout Los Angeles County. And some of those we do peer-run respites, which are alternatives to psychiatric hospitalization for people, where people live for 2 weeks at a time, either because they want an alternative to a crisis that's not a psychiatric hospitalization, or because they are coming out of a more restrictive setting, like incarceration, like a psychiatric hospitalization. And this is a step to reintegrating into the community. And then we have two wellness and recovery community centers, which kind of we get people that are falling through the cracks of all these systems and bring them into a physical space that then allows them to connect with people across the community. So the way that we do that is we bring together all the self-help support groups that would meet in the community. Think of 12-step programs and beyond. There are support groups for heart disease, diabetes, trauma. LA County alone has over 12,000 self-help support groups for 750 different life issues. So what we're doing is making this physical space the best space in town for those meetings. They're comfortable, they're beautiful, they've got Kleenex so people can cry. We support them with their needs. And then when people get referred to us through these systems, we connect them to the people that they see as their peers who are working on the things that they want to work on, right? For some people that shoot heroin every day, they don't think they've got a drug problem. They've got a problem with childhood trauma. And when we get them to the group for childhood trauma, they're supported by a broad community and network of social support across. It's not just people that are also receiving services at my mental health clinic, right? It's bankers, it's retirees, it's college students, it's people across the community so that people develop what's really important for thriving, which is a broad and deep social network.
There was a lot there, and I wanted to talk more about the peer respites and how they fit into the continuum of care. But first, you had mentioned that some of the peers working in your organization are out on the front lines. What does that look like? Because I think a lot of people are used to a standard concept of what crisis work looks like. Maybe police, maybe clinicians, very rarely are they thinking of peers on the front line. So, what does that mean? What does that work look like?
It is specific to the context that we're talking about. There are teams of people with lived experience and peers that are trained to go out with crisis teams that also include law enforcement teams. And the person with lived experience is able to connect with the person in crisis in a different way than the law enforcement personnel, right? Which is trained to handle something one way. As people with lived experience trained in peer services, our crisis response is informed by cultural humility. It's informed by trauma-informed practices, and it's informed by the specific elements of peer support that build relationships and elevate people's sense of empowerment and control. So those are things like, as a peer, when I use something called peer listening and disclosing, right? I'm able to take the experiences that I have, that I've lived through, and use them to connect with people in a way that reinforces what they're going through and provides hope. So this isn't just my journey of recovery. Like, well, I got clean and sober, so can you. Because when I'm on a crisis team, I might be interacting with somebody that doesn't think of themselves as having a drug or alcohol issue, right? So, and if that's my quote unquote recovery story, what I have to be able to do is listen to what the person's going through and then find that similar experience in my own journey and then use that as a bridge to connect to the person and validate where they are so that they can talk to me about what they think would be important for them. And I'll give you an example of how this is different in many ways. In Los Angeles, we have lots of what are called homeless encampments, right? People that do not have a place to live. They're in a tent somewhere. And our homeless services system has funded lots of outreach teams. So the outreach teams go, but like the police have one tool, the homeless services outreach team has one tool. They show up with a clipboard. Hey, can I get your name? You want some water? We've got housing for you. At one of the community meetings, there was a community member who lived in her car in the parking lot of a church. And the pastor was saying, this used to not be a problem, but the hours of the Sunday school changed. So now parents are dropping off their kids for Sunday school while she's showering and changing in the parking lot. And people think that's a problem. So is anybody familiar? And 4 outreach teams said they knew her and had been working with her for several months. And somebody asked, great, what are her goals? And none of them knew what her goals were. They said, we haven't gotten that far yet. And a peer in an outreach team starts with what the person's goals are rather than this arbitrary tool that this is what you need. We need you to move out of the parking lot and get into housing. So it builds on trust that is essential in relationships where people are going to be able to kind of define their needs and wants.
Yeah, you mentioned control, and I think that's one of the pivotal elements, especially when talking about working with trauma. The idea of how do you gain control of your own life? How do you gain the ability to direct where you go next? So in this continuum of care, how does someone who wants to connect with that peer respite, how do they reach out and coordinate that?
Great question. We try and create as many pathways as possible. So as a county provider, we often think that the county can't see anything it doesn't pay for itself. And that means that people aren't able to see it. And so we weren't able to really get a lot of referrals from county systems until we got county funding ourselves. And when we got county funding ourselves, we could go to all the provider meetings and take flyers and say, hey, this is what we got. These are the hours. This is the phone number to call, blah, blah, blah. This is how to connect people. So we do that, right? We go to all these meetings and all the providers know about all of that. We also make presentations at psychiatric hospitals, at behavioral health providers, substance use treatment centers. We also make presentations at housing programs where people are in permanent supportive housing, because for many people in permanent supportive housing, they might be 1 or 2 weeks away from losing their housing because of an issue. And we say, hey, if that's the case, send somebody to our peer respite and give them a break. It's rent-free, there are meals, and they can stay with us and then go back, right? And often they go back with resources that they didn't have going in, because often in permanent supportive housing, people's experience is isolation and loneliness, and we connect them to a social network and give them options for things that they would want to do. So the other part of that is what people get when they call us, right? So it's a self-referral system. So people have to want to come to the peer run respite. They can't be forced into it. And when we initially started, our peer run respite was funded by the Los Angeles County Department of Mental Health with innovation funding. And many other models were funded, and they kind of wanted to do the same outcome evaluation for each thing. So they wanted an intake. And we said, we don't do intakes. We'll do a welcome. We'll welcome people. And in that welcome, we'll get all of the information that you need for whatever you're going to do. And so we designed a welcome where we're able to explain the structure of what the peer respite is, and we're able to understand what it is that people want. We're able to open the conversation for questions. The peer specialists that take that phone call for somebody saying, hey, I heard about this and I'm interested. That person is able to disclose their own lived experience with similar kinds of settings and what their experience was, what was hard, what they found helpful. And then we can understand and ask the person what they might need from us for them to feel successful and that it had been worthwhile. And then we go from there. So I'll also say we have one peer respite in right now. We did a pilot program for people experiencing homelessness that went into a peer respite, where we did that program for 11 months, and 86% of people that came in who lacked housing, within 2 weeks, they moved out into housing. So it was either our peer run housing program, other permanent supportive housing with a subsidy, family reunification, or some people went to treatment for drug and alcohol use. And the other people, like there were only 14 individuals that we don't know where they wound up. And then there's a lot of word of mouth, because as people are kind of bouncing back and forth between systems and into the streets, there's a network of people who say, oh, you know, you need this, this is where to go. So our number gets passed around.
It sounds like part of what you're doing is reframing some of the core concepts from the models that people are coming from, like with the idea of not an intake, but a welcoming. Do those sorts of models limit you in any way as you're seeking funding? Are you being asked to accept the existing models, or is this sort of reframing being accepted by the partners and funding sources you're trying to work with?
That is a great question. And so much of what I would call the necessary revolution in behavioral health care begins with and includes the structures around what is funded. And for peer services, ideally what we want to be able to do, like our organization has this ethic that community is the method and the goal, right? 40% of whether human beings are okay or not okay is directly related to the amount and quality of social support in their lives. So our goal is to get them a strong community. And the way that we do that is to make them part of a community. And that means that if somebody feels like they're part of a community, there's something called the helper therapy principle that people have to experience. So that is when you have a mentor-mentee relationship, the person that gets the greatest benefit is the person that helps the other person. So if we're going to really help people, we have to nurture an environment where everybody gets to help somebody else. That way they're at their highest sense of self. They're contributing, they're adding value to relationships and community. Medicaid, Medicare funding makes it difficult to create that kind of environment because the funding is based on medical necessity. And our research is, decades long, but practice and policy are catching up to what we know to be important for people across all these different life issues. So the more that our system moves, and in California, we just have been shifting state funding to make sure that for every dollar the state spends on behavioral health, it can match federal dollars through Medicaid. And that's not a great system for developing community, right? Because we don't want people just around other people that have Medicaid. We want people around the broadest possible spectrum of community. So I would say that while providers often understand the value of services that exist in the continuum of peer services, the systems have not moved to really be able to adequately fund that kind of service so that it's available to everybody.
With this sort of community model, providing people an opportunity to find meaningful engagement, when you're trying to provide that for people who are either trying to avoid hospitalization or maybe coming out of hospitalization, how do you incorporate that into the peer respite? What sort of opportunities for engagement are people being given access to when they're at this peer respite?
Great question. And that's the secret sauce, right? That's where everything comes together. And we call our peer respite, the one that exists now, the recovery retreat. And it's a 2-week kind of program where we do 2-week cohorts. So everybody moves in on the same day and everybody moves out on the same day. We do that because that way nobody says, no, I'm not going out, because it's just that's the norm, right? We set the norm. We've never had a problem with that. So within that 2 weeks, what's happening is that people are running the house together as a community. Our peer specialists are kind of like the bumper rails in the bowling lane that keeps the ball from going into the gutter, right? And so there's a food budget, which we're increasing because of inflation. But since 2013, that food budget has been $5 per person per day. And people hear that and they go, no way, you got to make that like $20 per person per day. We can't do 3 meals, right? But then you get 8 people together talking and planning, and they think, okay, well, we've got $40. How do we get 3 meals today for $40? They're going to feed, and this person's allergic to peanuts, and this person can't have gluten, right? And you get enough people together and they figure it out, right? So they start collaborating, and somebody's going to be a great cook, and somebody knows how to do a great budget, right? And somebody knows the best way to, clean the sink quickly. So everybody's responsible for the house. So the day-to-day structure is a morning meeting where they plan activities. What are we going to eat? What are we going to do today? right? They might go to a museum. We have a 10-passenger van that can accommodate a wheelchair so people can go throughout the county for whatever they want to do. They could go on a hike, they could play basketball, and then they plan what self-help support group they want to go to in the evening. And we get people from all areas geographically of Los Angeles County. So people might be on different sides of the county, and we'll make sure that during that 8 weeks, we're getting to the community that each one of those 8 individuals comes from. So one night we'll go down to Long Beach for a meeting that that person wants to go to. And, one day we'll go to Santa Monica, which is on the other side of the county. And there might be totally different self-help support groups for totally different issues, but the people that are from those places in the county get to then develop relationships with people that have those issues in that area, so that when they leave the respite, they've got relationships in the community. So that's kind of like the general structure. And along the way, people have developed what we call, there's recovery planning. So we do recovery planning in a way that plans for long-term success. So right now we call this our plan for success. And we say, think of yourself as a success. 5 years from now, you are successful in every walk of life. What does your life look like? What do family relationships look like? What's your career look like? What do your hobbies look like? What's travel look like? And dream big. And we have a whole kind of visioning process for this. And then we kind of walk that backwards. Okay, if that's 5 years, what's 4 years look like? 3, 2, 1, 6 months, 3 months, next month, 2 weeks, 1 week. So people can start taking action right now on the things that they want to do and achieve long term. And then also, who's going to support you along that path? Who can you talk to about this so that things go from being dreams to being goals to being practices and tasks? And then within the day-to-day household thing, the thing that's going on that's really important, especially because 100% of our people have trauma. And I include myself in that category, right? So we're moving a bunch of people that are in crisis or on the verge of crisis, who are strangers, into a house, and they're going to live together and they're going to run the house. And 3 to 4 days, this is great. You're like the brother I never thought I'd have. This is amazing. Days 4 to 5 to 7, everything hits the fan. Nobody can stand each other, right? Because all of this stuff is coming up and people are on each other's nerves. And what's happening is people are developing the lived experience of sustaining and strengthening relationships when there's conflict and disagreement, right? So even though I can't stand the way you put your socks on, you had a really good idea about what we could eat today. And we're going to go together and we're going to get that food and we're going to make it together. And by the end of that 2 weeks, often people are exchanging phone numbers with people they thought they'd never talk to again, right? And so once that thing is in place for people, where they are able to strengthen relationships when there's conflict and disagreement, then they can really sustain social support, right? They can reunite with their family. They can maintain employment because they can work next to the person that votes differently than they do, or they can work for the boss that is not as smart as them, right? That's what's really happening for people in our peer-run respites.
So I think a common model for a lot of things is to find a singular focus, to find one thing that you're going to do really, really well. But with the diversity of experiences that you're talking about, the diversity of approach, going to different meetings, different nights, different skills being acquired, different opportunities being provided, how do you measure success when you have so many different factors to look at?
Our first measure is, are people happy with us, right? And if they're not happy with us, are they able to tell us? Are they able to ask for what they want? Is there a mechanism that makes for correction? And do they feel empowered to kind of initiate that process with us within that 2 week period? And often people are more than happy to tell us about their dissatisfaction, right? You didn't do this right. You didn't do that right. You didn't do this right. And we own it. And we say, great, what can I do differently? And one of the hardest things for us as peer specialists in this kind of environment is training our peer specialists to understand that it's not about whether we did or didn't do it right. It's about the person's perception. Like at the end of the day, I might, take what I've learned as a peer support specialist, I might be like on and do it great. And the person perceives that I was trying to control them. And that means that I have to change what I did so they have a different experience of me and a different perception. Our goal is always for people to feel supported by us so that we're increasing trust in the relationship. So we're strengthening the relationship. And one of the things that we use for that is a concept called the ultimate question by Dr. William Glasser, which is if I do or say, and then you fill in the blank, does it bring us closer together or push us farther apart? And we're always trying to bring ourselves closer together with the people that are coming to us in our programs and in our relationships. So, the other things that we measure, of course, are more concrete. Did the person move into housing? Were they connected to the supports that they wanted to be connected to? Did they attend self-help support groups? If they were looking for employment, were they successful in getting employment? What I would like to be able to do with the peer respite is be able to modify our funding so that we can follow people a little bit, because we get people for 2 weeks, right? And we know where they go after the 2 weeks and how they feel about that. But 3 months later, we don't necessarily know where they are unless they move into our housing program. Great, but that's just a side benefit for having a housing program. It would be great if people wanted ongoing peer support, if we could be able to follow them into the community wherever they are and continue to support them. And that's a kind of funding dilemma that we continue to work with.
There's something really important about being open to feedback and being open to criticism in an experience like this, because it could be both beneficial to the peer. They learn to receive feedback, they learn to adjust, and it can be beneficial for the person being encouraged to voice that criticism, that feedback. Because one of the things that still haunts me about my hospitalizations was that I didn't speak out more. I tried to comply as much as possible, even when I knew it was wrong. And I was afraid to give that feedback, to speak out, because I knew that there would be consequences. So I imagine that probably for a lot of people who have been through something like that, to arrive in a space where someone is telling you, I want you to give me feedback. I want you to tell me what's working for you. It could be really powerful to be in a space where someone is saying, safely saying, we want you to tell us when something isn't working for you.
Yeah. And so the other thing that we do is California is one of the last states to have a statewide certification for peer specialists. My organization, Share, is one of the trainers for that statewide certification. So we train the general certification, and then we're a trainer for all the specializations. And there's a family and parent partner peer specialist, there's crisis, there's working with people who are justice involved, and there's working with people who are unhoused. And one of the greatest gifts we can give somebody is to say, you're right, I'm wrong. What can I do different? Like, that's huge, because to your point, so many of the people that come to us, before they come to us, they're in environments and systems, whether it's family systems or institutional systems, where almost every day, all day, they are wrong. And they are made to feel wrong, and they are made to feel that they're the problem. And turning that dynamic on its head is one of the most empowering things that we can do. And it's counterintuitive, but it is completely disarming for people, right? It takes somebody that might be perceived as a threat and if they get to be right, they're not going to be threatening, you know?
So, over the last few years, there's been a lot of attention to changes in mental health laws in California, to conversations about involuntary hospitalizations and cost. So, I'm curious, how much does it cost to run a peer respite, as opposed to if the people there had instead been sent to some sort of inpatient facility?
Yeah. Our peer respite adjusted for inflation, and we support what we do with fundraising outside of our contract with the county. And so it comes to about $1 million a year, maybe like 959,000 and change. And last year we served 204 people in that peer respite. 84 people lacked housing, zero return to homelessness. So that's a lot of value for those dollars. And the other thing that you're touching on that is so important is, I was part of the design in 2008 of how Los Angeles addressed homelessness and housing. And there was a mandate from the Obama administration to end chronic homelessness. We never asked ourselves, how do we end homelessness? We essentially just asked for more money from the same system to do the same kinds of things. And that didn't solve the problem. And because that didn't solve the problem, and because we never asked that question collectively and addressed that systematically, we're in a place where the public that was paying for all those extra dollars says, yeah, this doesn't work. So we got to do something different. And they go to a more control-based system, which I understand. Like I can see. At the same time, I know that's not effective. I know that's not going to work either. And one of the reasons that it's not working on either side is because we're not asking the people the system serves what works, what do you need, and planning something that is deep enough and broad enough to cover everybody. And there are ways to do that. And I think arguably the cost would be much less. So, for example, there's an increase success rate of people taking their lives when they leave a psychiatric hospitalization. That is, decades of research on that. And what systems tend to focus on is, where are people going after a psychiatric hospitalization? Because that's the problem. But we're not going to what happens when they're there. Because what happens when they're there is they're isolated. They don't experience having control in their lives. They don't get to use their phone. They don't get to connect with their family. It's really difficult for families to be able to connect to a family member that's in a hospital setting, right? How do you make sure you can support the person with visiting them if the visiting hours are restricted to times when you have to work, right? So there are all these barriers for people getting the things that actually work. And actually I think it was the Center for Psychiatric Services published a report in 2021 that said one of the things that has to happen is that people with lived experience, peers, have to be in those settings, interacting with people and able to kind of create a sense of community and care in those settings. Because almost to a person, whatever system that we're talking about, whether it's the education system, the family services system, the homeless services system, the mental health system, by the time somebody gets to us, they don't experience those systems as systems of care. They experience those systems as systems of control. And the interactions in those systems make it harder for them to connect with human beings, make it harder for them to feel their own humanity, and create barriers to them using the system again, because they're not, I participated recently in a community kind of feedback session where a California legislator was trying to come up with legislation for the behavioral health system. And to her credit, she said, this isn't my area of expertise. So I need all of you here, people that experience the system, providers, people in the community. What are your thoughts? What are the barriers? And this was in the Skid Row area of Los Angeles. And one of the questions was, how do you experience the behavioral health system? And I said, okay, well, here I am. I live in Skid Row and I'm having an episode where I'm intensely threatened by everything around me. I think that people are coming to get me. And for me to go to the Department of Mental Health, I have to go through a metal detector, and then I have to interact with people who are armed, who think that I'm a threat. No way am I going to get through that, right? So the other thing that that does is, for people that work inside a system that makes humanity hard to recognize and feel, everybody in that system or in that environment has the experience of less humanity, less humanity. And so our goal is to bring more humanity into everything.
Yeah, I think that subtle paradigm shift of actually asking, what is it like to be the person asking for help? And I think far too often people with good intentions think that if their intentions are good, then why would anyone perceive them as a threat? A police officer, a clinician, a family member could have possibly the best of intentions. But to the person who is struggling with something, what they're experiencing is loss of control. And I think when we talk about trauma, we talk about, was it a 72-hour hold? Was it 1 week? Was it 2 weeks? Was it 6 months? But I think trauma can sometimes happen in one moment. And it is that moment where someone takes your autonomy, someone takes that control. Even if you're asking for help, you can be met by someone insisting they have to take that away from you. And you're being told this is for your own good. That can be all it takes to disempower that person, to diminish them. So, with the approach you bring to the work, are you actively encouraging conversations about power and power dynamics?
It is an essential foundational element of our training and all the training that we do, the experience of power and power over as opposed to power with, right? And so one of the key things that we do as peer specialists is to minimize our own authority, right? So that we're maximizing the sense of authority that other people have. And there's this, in the United States in 2025, we are products of a system that long before 2025 was very authoritarian, right? And was not grounded on unconditional love and support, right? There's a specific way to do things. And if you don't do it that way, you're wrong, right? Oh, you did it right. I love you. That's the experience of lots of people. And for us, unlearning that in our peer support specialists is really, really important. That people are safer and feel more connected when they feel that they have more power and more authority over what happens. And when somebody's saying no, that's really important. That is an expression of autonomy and power. And no, for many people, is a much more powerful thing to say, right? And so when somebody says no, we can say, great, I'm really glad to know that doesn't work. So how do we support the no around that? And we have probably a dozen ways of training people to address this fundamental issue of power. And one of the things is like, where is the boundary? And the boundary is, it's never between us, right? It's never like, well, this is the line. You can't cross this line because what's the next thing that happens? The person crosses the line because it's not about the line. It's about whether or not they get to do something and have power. And so when there's that kind of issue, we train our staff to always be on the same side as somebody, always be on their side, right? So then things come up. Well, okay, but everybody's got to be out of the house by 9 o'clock and one person doesn't want to go. How can I be on their side? I can understand them. I can make a change. I can say, okay, well, do we have to have somebody stay here? What's that look like? And what we find is that one, we're investing in long-term relationships with people, right? We have to be able to approach these situations that seem like the monumental decision is whether or not we get everybody out of the house at 9 p.m. That's not really that important. What's important in that situation is if the one person that feels like they can't do it feels supported. If we can get to that, then that's transformative for that person, for that relationship, and for how they orient to these kinds of solutions and dilemmas. And that's what we need to do for people, right? What we need to do for people is help them find a way through all these experiences where they find a way of addressing it that works for them, that doesn't alienate them, that gets them what they want. And part of that is the strategies for communicating what one wants and for having a network of people that support people in what one wants.
As we bring the interview to a close, is there anything else about peer supports or about the work you're doing? Anything else I haven't asked about that you think is important for people to know?
There are a couple things. So thank you. One is in behavioral health systems, peer support specialists are often seen as like a lower tier of the behavioral health workforce. And not enough people understand that peer services are really important at every level of behavioral health intervention. And one of the things that peers do that's really, really difficult that nobody else does in this system is like be with that person in that moment of crisis, right? A psychiatrist, a psychologist, an MFT is going to talk about something difficult in a safe space far removed from that acute crisis. The peer support specialist is often like with the person in the immediacy. I have been with people and had the police draw weapons on us while I'm supporting somebody, right? And their perspective on that is, do you see how they treat me? And I'm like, yeah, I do, And so the other thing that I think is really important about peer specialists is that, in a way this goes without saying, but it's something that somebody has to really want to do. It is not the de facto employment route for people in the behavioral health system. Oh, great, you're compliant with your medication now. Now we can talk about employment. You can be a peer, right? And accountants and engineers get told that, right? Oh, well, wait, I want to be I got trained as an engineer. I want to be that. No, but you've navigated through this system. You can be a peer. We need to find people that really are able to see their experience in others and not be judgmental. We're all judgmental. And there's an important distinction between moral judgment and information-based judgment. And there's so much moral judgment in this society that we have to look for people in our workforce that really have transcended that and are able to see and elevate the humanity of everybody.